And what I'm going to be speaking to you about is about conservative therapy in particular. I'm a physical therapist at Vanderbilt, physical therapy for persons with fat disorders, using evidence-based practice. And a lot of this presentation, you can see the handout that you can download, and there's references at the end, so that way you can kind of move forward and share it, look it up, any of that kind of stuff as you need. I think it might be where I'm pointing this to. Hold on. I got fantastic instruction, and somehow my big green button's not working. Oh, there we go, hold on. So these are my disclosures, but I don't think they have any potential impact on today's conversation, but I wanted to disclose. And for learning, today's going to be a little bit of a whirlwind, but we're going to talk about these conservative treatment strategies and looking at exercise and how to prescribe and tailor it towards individuals' needs. Also wanted to mention and discuss very briefly about motivational interviewing and additional resources that are available, potentially of help. So we've had a lot of great conversations about what is lipedema, and this isn't probably new information for any of us. I wanted us to all be sort of on that same page. The most identifiable component that a lot of individuals see or notice or start to talk to their healthcare provider about might be what we talk about SAT, that subcutaneous adipose tissue. But there, at any continuum of life, might a female notice something different about her body and the potential inheritance behind it. And back in 1940, what is interesting, these characteristic features with Drs. Allen and Hines and what they had written about with it being exclusive to women and bilateral, symmetrical, disproportionate of fat, not really involving the hands and the feet, potentially this orthostatic edema, minimal pitting edema, pain and tenderness, the vascular fragility, so that easy bruising potential, and then this persistent enlargement of this tissue that doesn't necessarily respond then to weight loss the normal way one would expect fat tissue to respond. So it's not really as affected by caloric restriction. And again, then maybe some women noticing by the end of the day, my legs feel heavy or achy. And so all these features actually were first noted and identified back in 1940, but then we have to kind of skip decades of it just not being addressed until now. And as Guy Eakin had mentioned this morning, fortunately over the last 5 years and more explosive over the last 2 to 3 years is the research that's being done on lipedema. Oh, and then the hypothermia of the skin too. So those are different characteristic features. In addition to with other fat disorders, Dercum's disease, like Dr. Herbst had mentioned, you can have lipedema and Dercum's together. It might be separate. It's a rare disorder. That's where NORD comes into play. And this adipose dolorosa, the painful nodules, they could be small, they could be large, they could be mixed. They could be angiolipomas as well. Also, the torso is more affected with Dercum's as well. What's fascinating here is that in one of Dr. Herbst's studies, there we're looking at a grid looking at the comparisons between lipedema women with Dercum's disease in women, and then the far right is Dercum's disease in men. And I think I put a little, oh, no, I didn't. Let me go back. I thought I put a little box around it. But if you take your eyes towards the hypermobility component is much higher in the lipedema women than as found with Dercum's cases. And so we're going to talk in treatment, so that component might be more specific with lipedema. Then I work with some awesome colleagues at Vanderbilt. You got to meet Dr. Crescenzi early on, and she's our principal investigator for many of our lipedema studies. And here with her colleague Shannon Taylor, who's also here if you happen to get to meet her, they look at MRI images. And what we're looking at here very briefly is just the adipose tissue, all of that white that you see in an MRI. On the far right, well, I guess it's your left, that is a person without lipedema compared to the other person where she has early stage lipedema. And then to either side, you might be able to see a little bit of their features, their age and their BMI. And the part that I wanted to hone in on is that we're looking at 2 patients where their BMIs are on the lower side. Lipedema is beyond fat. And so with the United States Standard of Care Committee that was recently published, that loose connective tissue disease is really a component that we'd want to look at. And it kind of starts to make a lot of these other components that we see that we would want to apply treatment for all start to make sense. But that reduced elasticity, this vascular and lymphatic involvement, and then psychosocial stress, and we're going to hear tomorrow further information about some of these different components that are super important in the whole continuum of care and quality of life for our patients, for any of you living with lipedema or fat disorders. The clinical diagnosis, as Dr. Crescenzi and others have mentioned, and it's probably not at all new to you, is oftentimes just overlooked, misdiagnosed as simple obesity, only picked up once lymphedema sets in, or is misdiagnosed as just lymphedema and missing the underlying lipedema, a whole host of issues. So further research is going to be very helpful. This is a slide that actually is familiar. It's very similar to what Dr. Crescenzi was showing earlier today in a treatment that we had done at Vanderbilt and recently published on. But what I want to highlight is the sodium map. Those are those colored maps. And when we look at sodium maps, the warmer colors are higher sodium content within the tissue, and the cooler colors indicate less sodium. So at the top here, this green rectangle is highlighting a patient with early stage lipedema. And I want to underscore that because with her early stage lipedema and also her BMI being very low at a 21.3, we're still seeing a high level of sodium within the tissue. The arrowheads and the black circle kind of indicating the muscle, the subcutaneous adipose tissue, and then also at the skin level, as compared to a female who is matched closely in age as well as BMI. And research is very difficult and it's challenging for a variety of different reasons, but some of these features are really important to try to match these patients who are with controls who don't have lipedema, so as to try to understand and disentangle what's going on. So just higher sodium levels. And then this I just wanted to show is non-invasive lymphangiography, and what we're looking at is 3 different ladies' calves. And then there is a person who does not have lipedema, but she is classified as obese, and she's on your far left. And then in the middle, stage 1, and then on your all's far right is going to be stage 3. And what I want to just quickly highlight through here is green arrows are going to be pointing out lymphatic vessels of congestion. And this is where we're kind of just seeing where we might be seeing it in all of these 3 cases. And then the green dotted arrows, more tortuous vessels. So that just means that lymphatic vessel is not as straight and indicating potentially some problematic or congestion. And that's in the lipedema stage 1 as well as lipedema stage 3. And then a blue arrow to note tissue edema amongst these different patients. And just to highlight and to underscore some of the differences here is that a patient who's got early stage lipedema in the center here, who is young and is of a lower BMI, and does not have lymphedema, her non-invasive lymphangiography shows a lot more lymphatic challenge than the control that is of much higher weight. So it's that conversation of what's pushing into a lymphatic impairment, lymphedema itself. Is it obesity? Is it lipedema? And so that's what this kind of helps to start to have a conversation around what's going on along internally. This slide that you'll have available in the handout is just a possible pathophysiology of the lipedema, kind of going down towards with the pain and the bruising and the edema, the lipolymphedema potentials. Now let's get to more of the important points that are going to lead directly towards conservative treatment. So here's a list of the common impairments that persons with lipedema would have, and also this has some elements then with Dercum's and other fat disorders. When a therapist are working with patients, it's important to understand pain levels and then to also disentangle between pain within the tissue itself, the lipedema-related pain, but then also the musculoskeletal, and that's what MSK stands for, the musculoskeletal pain from the wear and tear of joints, which is a real thing with added weight, with added lobules, added tissue that can then cause an isolated knee deterioration, that sort. We'd be looking at balance and walking and the hypermobility like Dr. Herbst had just gone through. That is a very real issue that clinicians would want to be evaluating for to appropriately intervene with the patients. And within the hypermobility then, how are the arches within the feet and what do we need to do about that? Muscle weakness, and then along with muscle weakness, incontinence, since our pelvic floor is made up of musculature. So looking at that and trying to help patients with any issues if they experience some. And then as we heard earlier with the speakers, the mental components that also go along with these disorders. So fatigue and stress and mindfulness or difficulties of remembering things, the concepts of mental health issues and depression that are real. And then in addition to it all, as Dr. Herbst had also mentioned, is also the potential for obesity, the simple obesity or the modifiable obesity, the something that can get changed as we would normally expect with movement and exercise. All these components very important to address. So as a part of the United States standard of care for lipedema, what I have here is this is where they have it specifically referenced about treatment concepts. Key focus is for education and awareness and to empower patients. So at Vanderbilt, we and a lot of organizations specifically talk about patient care, patient-focused decision-making. There are a lot of treatments, there are a lot of different options, and it's important to empower individuals and their care providers, their loved ones, to make the best decisions possible and how to kind of go down that trajectory. And then to continue to promote healthy lifestyle and the quality of life, as well as to ensure providing provision of personalized care. So not all of us are the same. It's very easy for me to even kind of think of this concept of if we were to go to a store and look for clothing, we're not all going to like the exact same style pants. It has nothing to necessarily to do with the shape or the size, but it might be the color, it might be the fabric, it might be a lot of different things. I'll even notice I can't even go to the same location and be able to just order things online. It's like trying it on. It's all the decisions and the feel, everything kind of needs to be personalized. What works really well for one might work okay for another, but something else is better for that person, or it's a different concoction of intervention. And then with it, it's very much beneficial to have a multidisciplinary approach. And this is challenging. It's, people will ask, well, how do I find clinicians that know about this condition? And being a lymphedema therapist for many, many years, we always referenced lymphedema from cancer even, being the red-headed stepchild of all the other conditions and diseases. And so really what it gets down to is now lipedema is the red-headed stepchild. And now we've got Dercum's disease, and we've got Madelung's, and we've got stem cells, and it all becomes, oh my goodness, how many red-headed stepchildren are kind of moving down? It's hard. And so, and if you know anyone else who has another type of rare disease or disorder, or just something that's not as easily found for finding clinicians, it's us being our own advocates for patients and as clinicians to try to find ourselves in places like this that can be super helpful in networking and improving access to care, but also increasing research dollars like we heard earlier as well. So with that said, this referral system is coming from the mindset of myself being a therapist and the referrals that are made out there, nutrition clinic, and they're not in any particular order, but psychology and psychiatry, vascular medicine, surgery, whether that be the bariatric related surgery for weight loss or the liposuction procedures, women's health in particular, I'm underscoring that pelvic floor again, podiatry, integrative health services. There are a lot of these systems now medical providers are providing more holistic care. And at some of the universities, Vanderbilt specifically has the Osher Center now. And so there's a lot of different alternative medicine that are available in mainstream medicine to try to bring it all together. I just wrote meditation of one of many different options, as well as wellness coaching, and being connected with a lymphatic therapist who's certified, and also a compression specialist. So with these conservative therapies, not in any particular order, but we've got nutritional care, manual therapy, we can provide compression garments, pneumatic compression devices, and home exercise plan. These are not all, there's so much that can kind of go in each one of these different categories. This is just sort of the overarching, and then additional clinical referrals that we can make. With nutritional guidance, again, the U.S. standard of care touches on it, and as Dr. Herbst already said, so I'm going to kind of blow through this pretty quickly, eating plans, they're going to look at reducing the amount of glucose fluctuations, and sustainable. That's the big component. It's an eating plan for life. And I've never liked the word diet, but it is, everything that we eat is a diet. But it's a sustainable eating plan for people to be able to eat. In particular, we're going to hear more about this, and what Dr. Herbst had already mentioned for the different types of foods, and low carbohydrate seems to be a huge key, and nutritional referral should always be considered. Obesity is definitely an epidemic, and unfortunately it's not reducing at all. And it doesn't specifically just apply then for lipedema here. I bring it in because I've got 2 young kids, and it's obesity is rampant all along the continuum of care, and it's just an important concept for all of us to kind of be looking at what's around and how can I make my own personal changes based on the knowledge that I'm empowered with. So with the United States, obesity has only continued to increase rather significantly over the years. And here's another graph of showing the obesity trends. What is important to understand too, though, is lipedema is distinct from obesity, even though an individual could have both, and we saw some great examples from Dr. Herbst's presentation just a moment ago. It's still a very distinct entity, and it requires then other thinking. But with that said, that might be where, with nutritional plans, people are finding some success in losing weight and feeling better and being able to move better, and that's what it's all about. So moving forward with manual therapy, the purposes of manual therapy is to reduce pain. That's the hands-on techniques that therapists would be using, improve tissue mobility, reduce inflammation, and improve the musculoskeletal restrictions around the area, and also to stimulate the lymphatics and reduce edema. The techniques that are used are all sorts. They're going to be deep and superficial. We're going to meet the tissue where it's at with restrictions. We're going to manually work to reduce the pain. And what you see for a picture there, that's just another type of device. Instead of putting pressure onto the tissue, it stretches and mobilizes the tissue away from the body. Myofascia releases and different tools. Dr. Crescenzi mentioned this earlier already for one of our studies, and the component I want to underscore is that with a real quick, basic 6 weeks of treatment, patients' quality of life greatly improved with these different types of techniques, where mostly manual was being utilized while patients were then exercising in between each of the visits. And then in addition to pain scores drastically reduced as well, which was rather exciting. This particular study that Dr. Crescenzi and I were a part of, they were patients I would not have seen in the clinic otherwise, and that's what was exciting. They were early stage lipedema, and they're not referred to us right now at the clinic at that stage. But they had great improvements in their quality of life. So Dr. Herbst just went over all the swelling components and whether we want to, or whether it's there or whether it's not. The key then from a therapeutic end or for an individual is if you notice your legs are full or achy at the end of the day, they shouldn't be that way. And so compression can be a wonderful way of changing that. What does that compression look like? It's going to look very different from a person who has actual lymphedema. If you're a person who has lipedema with lymphedema, then it's going to be treated along those lines with like lymphedema. But when you don't really have but just an achy legs or just a little bit of that swelling, it could be something where there's much less containment. It could be micromassage, which I'm happy to talk to people about that more later. It could be flat knit versus circular knit. There's a lot of different components within compression. Most importantly with compression, it's gonna depend on the person, and it needs to be comfortable, and it needs to be something that they can put on. It needs to be able to manage their edema if they have edema, and there's a whole host of selection of sizes and fabrics and materials that this time I have with you right now does not going to allow for that. But what I have here on my slides is a lot of information for people to kind of look at later or reference, but here is what we've got in the US standard of care. Pneumatic compression devices are also helpful for stimulating lymphatic flow, and in particular with lipedema, my patients have noticed it really helps to reduce their pain, and this is a self-management component. So with exercise itself, people are going to benefit from continuous regular movement and exercise. It needs to be individually prescribed, started slowly, meet a person where they're at and what they're interested in doing, and slowly pace progression to increase their tolerance and their interest. What you like to do. This particular study is outlining that there's a strength issue identified within lipedema itself. We talked about that pelvic floor weakness, so if there's a strength issue, we would want to ensure that patients or anybody who's having incontinence would be knowledgeable of exercises that they can do, and it's in this slide here. So in the interest of time, I'm gonna have to blow through all this. But with progression of exercises, therapists are going to be helping people with balance impairments. They're also gonna be looking at joint proprioception so as not to to have an appropriate awareness of their joint and not hyperextend. Some people we're just not aware of it when we can hyperextend. We're used to it. A therapist potentially would use the Beighton score to be able to identify how much extensibility there is. And what are we doing as a therapist? We're trying to just help to teach a person how to hold their body in the right way so as not to put extra wear and tear on their joints. With strengthening and with land, you can do any of these things. And the main component is I want to emphasize water. Water is so beneficial for so many of our patients with lipedema. I'm unfortunately going to have to blow through a lot of the rest of this. When people are setting their own goals, because my time is up, use it specific goals, make it measurable, make it relevant. Because in chronic diseases, most of the time a patient needs to do their own self-care. It's only the tip of that iceberg that professional care is a component of it. So it's a lifelong thing, it's a journey, and self-care is important. So what I have here, and all the slides are available, and you can ask me any questions that you have. It's just too much to try to cover within 20 minutes. But this information is in the handout so you can download it. There's lots of different barriers, and I'm trying to finish up. When we work with patients, we want to empower our patients, and that's what all this information is. There's lots of wonderful resources. I have it all there, and you can go straight to it or you can bring your clinicians to it. You can download all of it, and these are my awesome people that I get to work with. So thank you very much, and there's all the references.
Just wanna